Hi, this is Andrea Miriam with PMD Alliance. So grateful that you are joining us today to learn together. I will start by going over some usual housekeeping items. The program is going to be recorded, and the information we'll go over if you email us. We're happy to email you a copy out. So I always like to mention that so you know you can give your full attention and really soak it in and know that the information is available afterwards. We have the transcript or closed caption feature on, so if you'd like to see the words on the bottom of the screen, and I think it's done with AI, so they don't always match up to what I'm actually saying, especially sometimes I like to try to trick the computer and see what funny transcription they come up with. But you can toggle that on or off, and the way to do that is that more button, the three dot ellipsis in the bottom menu. You can turn that on or off. And then we already have someone participating in the chat. Um, we love when these events are interactive and you're not just, sitting there, but can react real time, ask questions, talk with each other. And as an introvert myself, I know sometimes that's my preferred method of communication, to just have a little chat storm typing going on. So I invite everyone to participate in the chat, and I see Gil got things going, chiming in that he is in hot and steamy South Florida. So we were just talking about the weather. Maybe let's practice with the chat, and feel free to type in where you are tuning in from. Is it fall yet? Is it sweater weather? I love that Saturday Night Live clip. So, oh, okay, we have both. We have Floridians and Canadians. So that's both ends of the spectrum. Maybe everyone else falls somewhere in between. So I think that's all my housekeeping. We have a couple PMD Alliance staff on, so if you have any tech problems you can't hear or see, there's Kelly and Calissa ready to troubleshoot. So you can always put that in the chat, and then we'll send you a private message to help you out. So I think we are ready to get started. It is my dear pleasure to introduce our expert speaker today, Dr. Jill Farmer. She's a DO MPH in the Philly, South Jersey area, a movement disorder specialist. And Dr. Farmer, I think you're fresh on the heels of returning from the International Movement Disorder Society meeting, right?
I am. We just had our first live meeting in Madrid this past week, and it was a pleasure to be back seeing people and interacting with colleagues from around the globe and industry and learning, what's to come. Some of it was basic science and research and pathology, but some of it was more practical with new medications and things on the horizon. So a question I often get asked in the clinic is what's new, what's coming? And there is a new pump that is coming. It's due to get its FDA approval, fingers crossed, the middle of October. So just a couple of weeks away, and then be utilized for clinical use the end of this year, beginning of next. And it is if anybody is familiar with the medication Apokyn, the injectable pen, this would be a pump that delivers the same type of medicine subcutaneously under the skin for 16 to 24 hours a day. So it's everything that we're looking towards in the future is to continuous delivery, more consistent medication dosing to prevent that up and down, peak and valley that Parkinson's patients experience.
Wonderful. Well, we love breaking news,
Yeah.
hot from the international conference.
Yeah.
So thank you for sharing. And that is a great segue to what we're going to talk about today. So many of you might have participated. We did a survey about off time. We sent that out to our audience. Oh, I forget. I think it was about 6 months or so ago, to find out both from the people living with Parkinson's or care partners, family members, the experience of off time, how you talk about off time and symptoms with your healthcare team, and as many of you put in the notes after you filled out the survey, I'm going to get these back, right? I'm going to find out what everyone else said. So we wanted to gather everyone on Zoom to talk about the results of that survey and just kind of open it up and have an open discussion. So feel free as we go through the results, if you have questions, put them in the chat, and we will work them into to what we're talking about. So let's see. So first off, Dr. Farmer, I think what everyone who reviewed the survey, their top line interest had to do with, and really the name of this program is Good Enough, Really Good Enough, had to do with the results about off time and the perception of off time.
Mhm.
So I'll just start by mentioning what the percentage, what everyone said. So it was that 86% of people with Parkinson who experience off time said it had a significant impact on their quality of life. So for those folks joining us, in nodded heads, thumbs up, off time affects your quality of life. Is this sounding right? Sounding like things that you'd agree with? And then the follow up stat was that 56% of people thought that their symptoms could not improve. So, Dr. Farmer, what does that data point, what did that data point scream out to you?
So more than half of people not thinking their symptoms could improve honestly makes me sad. Um, and it is something that I think we can absolutely improve upon. Um, Parkinson's patients are realistic, and I think many movement disorder specialists and neurologists that see them are also somewhat realistic. And we know that we are dealing with a chronic progressive condition. But I also don't like taking away hope from people. And I feel like we are fortunate in some way that we have so many options available to us for treatment, oral therapies, rehab therapies, surgical therapies, whatever it might be. Now, interventional devices like these pumps that are coming out. So when I see that 56% of people don't think that anything can be done to improve their situation, I'd like to have a conversation and figure out what it is about their situation that they don't think can be improved. And I would say that there usually is something we can build upon. Will improving the situation be that it makes all the symptoms go away? Probably not. And that's where we know that managing the expectations of what we can do. But is there something that we can do? Can we help your morning off period a little bit? Can we potentially get that lull in the middle of the afternoon that despite making changes to your medicines, you're still experiencing? Could we see if there's anything that can be done for that? Possibly. And it might not come with medicine. It might come with behavioral intervention or other things, but we have a lot at our disposal that we should still try. So I feel bad if people think that there's nothing left to consider to address something that might be bothering them.
And Judy put an interesting note in the chat that, maybe your physician or care team, Judy, has told you that you'll never get any better. So I think to peel back some of the layers, Dr. Farmer, how do you have that conversation with your patients? Well, yes, Parkinson's isn't curable, but it's not always completely black and white.
Sure. So again, I try to really, as you were saying, peel back the layers. I tried to narrow down what the expectation is of the thing that we're trying to get better. So if someone has had Parkinson's for 25 years, they've been maxed out on all meds, they've already had DBS, and they're still functioning, but not to the level that they would appreciate, that's going to be a different conversation about what we can expect for improvement of symptoms to somebody that's had Parkinson's disease for a few years, is only on a couple of medications, and is nowhere near a threshold of maxing out any of them. So again, if you're in the first category, it's about 10 years in, you're on 2 or 3 different meds, you're considering maybe doing some surgery, but the thing that you're really bothered by is sleep. I'm not necessarily going to address that with Parkinson's meds. I'm going to address that specifically for sleep, either behavioral interventions, adjusting different medications more specific for sleep, looking into types of therapies, whether it be light therapy or meditative therapies, behavioral therapies to go about helping with sleep hygiene and things like that. If you are asking and trying to figure out if a morning off period can be addressed, but you haven't tried any, on-demand therapies, that would be a conversation to have. If you are wondering if you're having excessive dyskinesia, but you're also experiencing off periods, is there something that can be done? If medications haven't been adjusted specifically to address the dyskinesia, and then looking at the off in kind of a stepwise pattern, there's always something that can be considered, even if it's revisiting something you have done in the past, because your brain chemistry at this point in time is different from what it was months or a few years ago. So you might respond differently to therapy that you've already tried, but didn't necessarily have a good outcome with. So that's why I say it takes a lot to really say that there's nothing else that can be done.
Very good. And that's fascinating to hear that even month to month that things change.
Mhm.
And so don't rule out, okay, this didn't work. So, don't mark that out in black Sharpie,
Exactly.
and have that conversation with your physician,
Mhm.
um, and stay open.
Case in point, I had a patient this afternoon, right before the call, who is terribly under medicated because they're so sensitive to medications. And we have come off essentially all dopaminergic therapies due to side effects of whether it is nausea or excessive sleepiness or whatever it might be. We I'm aching to give this patient some form of dopamine because I can see how their body just needs it to function. And we had the conversation again. I know we tried this 6 months ago, but you tried the supplement of dopamine, the over-the-counter, supplemental form of dopamine, and you finally tolerated that for the first time. Well, now there's a new scored pill of carbidopa levodopa that you can break into very precise quarter tablets that you might be able to tolerate better. So let's revisit looking at doing this again. So again, from a visit that was initially started with the thought of, I don't know what we're going to talk about today, there's nothing more we can do. There is always something that we can revisit or reconsider to see if it might be helpful.
I know maybe people have heard that in their support group, that
Mhm.
people often say, I hear it a lot, oh, I've tried that and it just didn't work for me, both about medication, but also maybe about PT or OT or speech
Mhm.
therapy. So that's a great reminder to keep an open mind about
Mhm.
things and leave them on the table. The next stat that I wanted to go over had to do with effective versus optimal.
Mhm.
So, in the study, 89% of people accepted that experiencing symptoms is part of the disease. So,
Mhm.
89%, that's a pretty overwhelming majority. And yes, realism and, you're living the symptoms. Yes, that is definitely a reality. Can we talk about the difference between accepting the disease in your life and accepting management of the symptoms?
Mhm. Sure. So I have to say that I am guilty of using the phrase and the terminology, well, is it good enough? And I don't mean that as a flippant or a dismissive comment. I mean in there is, as everybody who's on this call knows, there is a balance. There's a balance between treatment and potential side effects. And we're looking to get the best response with the least amount of side effects. So when you're saying things like, oh, it's good enough, in the clinician's term, it's you're able to function the way that you feel is adequate so that you're able to do the things you want to do. You might have to adjust how you do them. You might have to adapt in some way, but you're still able, for the most part, to get through your day, to get through your physical therapy and your activities, to go out and socialize with minimal impact by the side effects of the medication or your Parkinson's symptoms. Does that mean you're optimally managed? Not necessarily. You might still get a breakthrough tremor here and there. You might still feel a little tired after you take that dose, but you kind of wait it out and then you're able to go on about your business. So it's not without any symptoms whatsoever, but you're able to do the things you want to do and need to do. It shouldn't be that you're trudging through the things that you're still able to do, but it takes a lot more effort than you want to give it. So if that's the case, yes, it's not good enough at that point. It's managed, but it can absolutely be improved upon. So in my head and in my terminology, when I'm having this conversation with patients, that's sort of how I delineate when new interventions or new treatment strategies or thought processes need to be entertained. And I try to educate my patients that that's the thing too. I don't want you to think it's going to be perfect because we know that it's not. We are dealing with a chronic condition. There are symptoms that we expect to be present. And if you're able to manage them to a point that's satisfactory for you, then that's good enough for me. If you're not, then I want to have that conversation and we can either discuss, is there additional interventions that we can do? Or do we have to kind of rethink our expectation of what the medications and the rehab strategies and things like that are going to accomplish? 9 times out of 10, there's usually something we can do. Adjustment to the frequency of meds, adjustment to the dose, adding another complement, discussion of the on-demand therapies or surgical approaches or things like that. And if that conversation is difficult to have, either because your doctor's not asking or you're not quite sure what to say, have an honest discussion either with yourself or with your care partner to say, what are you noticing that I may be ignoring or I may be downplaying or whatever it might be? Because those are the things that we need to hear. If we hear and everything's fine and that it's good enough, then depending on the day we have, how stressed we are and how busy it is, we may or may not be able to delve in and kind of dig beneath the surface a little bit. So sometimes being as open and forthright as you can helps the visit go in the direction that it's supposed to.
Mhm. Yeah, I think so many people have that stiff upper lip,
Mhm.
keep calm and soldier on. And it can be tough to know when to bring up a symptom, as bothersome to your doctor. And so maybe I wonder with the folks here on the call, when do you bring a troublesome symptom? Like you mentioned sleep. So sleep, let's use that one so we have um, something concrete. So, do you wait until it is a 10 out of 10 and you haven't slept for, you're having just such extreme insomnia that you are sleeping 30 minutes a night? Or do you bring it up with your doctor? And I'm asking all of you, and it can be any symptom, or when it starts to be different, or it starts to maybe affect how you live your life. Are you bringing it up at the beginning of the symptoms. So are you waiting until it's a 10 out of 10, or are you bringing it up at right when it happens, like a 1 out of 10 or a 2 out of 10? I'm just curious of the folks who tuned in today, what level of good enough, what does that mean for you in how you talk to your doctors? So I love for people to put an answer in the chat, and if an easy way to capture that would be, do you, how about in the out of 10 scale? Do you bring it up when it's a 1, like just slightly notice it, or a 10? Okay, so our fast fingers, Lynn was the first to reply, 6 or 7. Okay, Nick brings it up at a 3. Very good, very communicative with your physician or your care team. And if you got to pick, Dr. Farmer, when you wanted to know, from your patients,
Sure.
what the ideal, how on that scale of 1 to 10 of bothersome to impacting quality of life severely, is there a perfect answer that you would want your patients to bring things up with you?
So I would think that for those that are going with the 7 or 8, I'd like to see you bring it up a little bit sooner, because 7 or 8 seems like it's pretty impactful at that point. So the 3 to 5 I think is great, because at the 3, let's say, it's not like we're going to overly react and make a grand change, but it's on our radar now. So at least, if nothing else, I'm making a note in my note to ask you about it at the next visit. And that visit for me may be 3 or 4 months down the road. 3 or 4 months, maybe sometimes just the tincture of time helps whatever that issue is. And then we ask about it, and it's okay, and we don't have to address it again. But if it's still persistent, not necessarily worse, but persists, that lets me know that it has some staying power, and it's something that we should address. Because with anything from motor symptoms to non-motor symptoms, the sooner intervention is applied, most likely the better the outcome is going to be, because you can address it with usually a lower dose of medicine or a less prolonged course of therapy than you might if you wait for it to get to that 7 or 8 out of 10 mark. So sooner is always better. And like I said, not if you bring up something and it's mild and you feel like your concern has been dismissed by the physician or the provider that you're seeing, say, I know this might not be, compared to other people, a really big deal, but it's becoming a bigger deal for me. And that's honest, and it will make that person take notice. Whether or not an intervention can be done at that time, again, depends on a lot of things, but at least it is part of your record and part of the clinical picture that we're going to be paying more attention to going forward.
Very good. And this was a good question for Mary. From Mary, she said, a lot of times I don't have the vocabulary to bring it up. I just know that something feels different or wrong, but I don't have the words to match with what I'm feeling. So how would you counsel Mary? They don't, as a patient or a loved one, you don't need to go to med school before
No.
your doctor's appointment. Is it okay to use, unspecific language?
Yep. I'm not necessarily a fan of medical jargon. I don't tend to use it in my clinics when I'm teaching medical students and residents. My most common phrase is describe what you see, because that is just as beneficial as using the quote unquote term. If you have the time to talk through what you're feeling with non-specific language with your doctor, so you can come up with a term or a better understanding of what that symptom might be, that would be the most ideal, because it's unique to you and you know what it is, and it's a good reference to have. if you don't have the ability, the relationship, the time to do that, there are wonderful online resources and checklists and questions through, a lot of the advocacy programs, PMD Alliance, Parkinson's Foundation, whatever it might be, like things to talk about with at your doctor visit. And you can use some of those terms that if they're not exactly what you're thinking, they're close, and it could get you nearer to the things that are more specific for you. But you're right, it is important to kind of have some sort of vocabulary. And if you're not able to kind of tease that out yourself in conversation, it might be an awkward conversation, especially if it's nothing as obvious as a tremor. If it's a feeling of uneasiness in your skin, or an irritability, or if it is excess sweating or excess saliva, or a feeling of doom, like especially when we're dealing with the feeling, I don't feel quite right. I feel like something is off. I feel like I am just not quite myself. Like these are all vague. But if you can kind of dig down and say, if somebody tells me I just feel like I'm not quite myself, usually my next question is, well, what are you doing when you feel like that? And if they're like, well, I'm just sitting and I'm watching TV. Okay, when was the last time you took your medicine? And if they say, oh, I'm usually due for my next dose, well, that is something that we can kind of work with. And sometimes it leads us to an aha moment, sometimes it doesn't. But again, it's trying to work through the vocabulary to get to something that is familiar enough to use on a repetitive basis, so that we know that that's what your off period and your off feeling is like.
Very good.
Mhm.
And she did follow up that sometimes I don't know if it's the fact that I'm 83 years old or Parkinson's. I don't want
And
to complain too
that
much.
is an astute observation, and it's something that we say constantly. Like when I have patients who are 89 and they tell me, I just feel so tired all the time, and I'm like, well, there is some of that is related to age with your chronic medical conditions plus all the medicines you're taking. So nothing happens in isolation. We can't just blame it all on the Parkinsons, but it also shouldn't be discounted because of your age. Like you shouldn't just chalk it up to age, kind of a thing. But it does play a role as part of the context of some of the things that people are talking about. Stiffness is another one. Stiffness is a big thing in Parkinson's disease. Of course, it's one of the things we ask about. But if you get the story of, I'm really stiff in the morning, but I get up out of bed, and after I move for about 10 or 15 minutes, like things start to loosen up and I feel good. And it's before you've even taken your dose of medicines and stuff like that. That's usually more arthritic changes related to age than it is the stiffness that comes with Parkinson's disease. But there is a lot of overlap, and sometimes teasing out which it is difficult. And we're left with, does it respond to meds? Does the symptom that you're describing respond to the Parkinson's meds when you take it? And if it does, we say, okay, then some of it, if not all of it, is related to Parkinson's. If it doesn't, then we're still kind of stuck with, we're not quite sure what's playing the biggest role.
And when you're seeing a movement disorder specialist, I think they know Parkinson's so well that it takes a lot of the burden off of you as a patient or a family member, that you can use layperson language or describe, and experts like Dr. Farmer will know what are the medications, what are all of the very many diverse symptoms of Parkinson's, and have a good place to start. Okay, maybe this is a good. So Anne wondered, lightheadedness, could that be something that is related to off and Parkinson's?
Absolutely. So lightheadedness, again, that's a term that is, not med specific. So we have to tease it out a little bit. Is it something that you experience when you change positions? Is it a feeling of imbalance on your feet, or is it a feeling of swaying and rocking and room spinning and things like that? Is it the kind of feeling you feel like before you pass out? So trying to tease out a little bit more specifically as to what the lightheadedness is referring to. But let's just say lightheadedness, for the sake of keeping it simple, is just a feeling of feeling a little bit woozy, kind of have to catch yourself. And it happens when you change positions, mostly squatting to standing up, lying to standing, lying to sitting, sitting to standing, whatever it might be. Absolutely, that's related to Parkinson's. It's related to the fact that blood pressure tends to be lower in patients with Parkinson's disease over time. And that reflex to kind of constrict the blood vessels to push the fluid back up to the brain when you change positions is slow, the way other things are slow in Parkinson's disease. So why we always ask, do you drink a lot of water? Because if there's fluid in those blood vessels to push back up to the brain when they squeeze, that lightheadedness is less. If it's not related to, if you're drinking plenty of water, but it's still happening, it's really a function of that slowed response and that slow reflex. So there's medicines, again, that can be used to help prevent the blood from dropping too much, the blood pressure from dropping too much without raising it. It can also be exacerbated by the medicines you take for Parkinson's as well as other things. So oftentimes if we hear this concern, we'll do a med review and see if you're on 2 or 3 different blood pressure medications. It might be time to either come off of some of those or reduce it. We'll look to your diet. If you're on a salt restrictive diet or a fluid restrictive diet, then we might have a conversation with your other docs to see if there's a happy medium we can find to help with that. But yes, it's something that's related to Parkinson's and also the medicines that you might be on because of it.
That was a great example. So I'm glad you mentioned that, Anne, because you can certainly, we've all been lightheaded through our lives and not necessarily something that is on that, top 10 Parkinson's symptoms list, but as Dr. Farmer just dug into, so many connections that your physician would want to peel back those layers. The next section of the results go into off time, and I thought before we start diving into off time and assuming that people know what off time is and how we're going to be referring to it. If we could start, Dr. Farmer, can you explain, just broad picture what
Sure.
off time means and what off in Parkinson's, as a basis for the next couple of questions?
Sure. So this idea of vocabulary is not something that is unique to patients. Docs and movement disorder specialists themselves will spend hours trying to define what off time is and coming up with the proper terminology and things like that. So it's really important. The working discussion points for off time are that when your meds are working and the symptoms have improved, you say that you're on. When the medicine wears off and your symptoms return, we say that things are off. And off can be further delineated into certain times and certain types. So before you take your first dose of medicine in the morning, if you notice that symptoms are at its peak, because that's the longest time you've been without any dopamine supplementation of some point. So that we call that morning off. If you're taking your medicines very regularly, about every 4 hours or so throughout the day, and you can tell that when you're due for your next dose, some symptoms start to return, a little bit of a tremor, a little bit of stiffness, slowness, some of those non-motor things, foggy feeling panicky, sweaty, just uncomfortable in your skin. That is a wearing off phenomenon. Then there's times when you take your medicine and you wait and you wait, and what should have been 10 or 15 minutes to kick in is now 30 or 40 minutes, and you feel the medicine starting to work. That's a delayed on, which is also another form of off. And then lastly, it's when you take your medicine and no matter how long you wait, nothing happens. That's a failed dose, and that's a complete off period. And it can it can happen unexpectedly. It can happen, when out of the regular cycle of when you're due to take your medications. So those tend to be the 4 main types of off periods: morning off period, wearing off, delayed on, and just failed doses of medication.
Thank you. So in the survey, we asked people what what leads to off time, and it was interesting that it was. Um, we asked if it had to do with time of day, and people said it was less time of day, and it was more stress and exhaustion.
Mhm.
So stress and exhaustion led to more off times. Can you explain in the body, how stress might be connected to off time?
Sure. So I often tell patients, again, I'm a movement disorder specialist. So while I mostly see Parkinson's, I see other things as well. And there's another entity called functional movement disorders, or the older term for this was conversion disorder or psychogenic disorder. And these are conditions where there is a stressor on the body. It doesn't need to be at the exact time of the movement, it just needs to be in the patient's history and past in some way. That manifest themselves as an abnormal movement. And the reason is you cannot untangle mood and movement. Um, if you have Parkinson's disease, you're already predisposed to an abnormal movement, whether it's tremor, whether it's stiffness, rigidity, whatever it might be. So if you put a stressor on the system, it's going to exacerbate that movement and really make it blossom, because you already have that tendency towards that movement to begin with. Say you know someone who doesn't have Parkinson's, but they're about to stand up and give a talk in front of 225 people, and all of a sudden their voice starts to quiver or their hands start to shake. Again, that's that stress response that's being manifested to movement. So they are connected. They're connected chemically in the brain. They're connected in pathways in the brain, the motor pathway and the emotional pathway, the amygdala, and all of that are all parts of the same circuit. So it's not rocket science that they would clinically be relevant to one another. And I have this conversation constantly with patients because it's not, again, dismissing someone's symptoms and relating it just to stress. But the reason why we talk about your mood, the reason why we talk about anxiety, the reason why we talk about depression is because it will have an impact on the motor symptoms you're experiencing with Parkinson's disease. So even if I treat your tremor as optimally as I can, if you're in a stressful situation and that tremor comes back, doesn't mean your tremor and your Parkinson's is inadequately managed. It means your emotional response is. So there are strategies that we need to discuss and talk to about that. And it's not easy. And it's not to say that it is, one approach is better than another. Really, it's a combo and a dual approach that needs to be comprehensive.
And I'm wondering if there might be a vicious cycle
Mhm.
where you are stressed causes you to go off, and then you are stressed about going off and
Yes,
then just trapped in this circle.
it is. It is a cycle. It is a hamster wheel, and trying to break that is difficult, and hard. And that's why for some patients, taking a dose of an as needed anti-anxiety medication, a lorazepam, an alprazolam, whatever it might be, is the way to help break that cycle. And it, it is so common in Parkinson's that it is absolutely a conversation that should be taking place.
Thank you for that. I wanted to make sure we're um, responding to the questions in the chat, and we'll start to pepper those into
Mhm.
the survey results. And some of them are kind of connected. So Rhonda mentioned gastroparesis,
Mhm.
and Lynn was asking about failed dose, and if
Mhm.
that means is it a bad pill or the body isn't accepting it? So I thought those might be
Yeah.
combined questions you could answer.
Sure. So I wish we could blame it on the pill, but it's probably not the pill. It's really most related to the first question about gastroparesis or just slow GI motility. As I tell patients constantly, when things are slow on the outside, they're slow on the inside. So when you have slowness of thought, can't find that word, it's on the tip of your tongue, but it's not coming out. That's called bradyphrenia or slowness of thought. Slow movement is called bradykinesia. So you can see that they're connected in clinical symptoms and presentation in Parkinson's disease. Well, the same is true for your gut. There's no Brady related to the gut, but it's just gut dysmotility and GI dysmotility, where things take longer to pass through. And that matters because Parkinson's disease medicines are really only absorbed in one place. They're absorbed in the first part of your intestine. So you have to swallow them, break it down, goes into the stomach. The stomach then has to release it. And when it gets out to the first part of the intestine, that's where it gets absorbed. So if that gut motility is slow and it stays in the stomach for too long, those stomach juices and gastric enzymes are going to break it down before it even has a chance to be absorbed in the intestine. So that's the most common reason for a failed dose. That's why looking at medicines that either are delivered directly into the intestine through different pumps are an avenue of delivery that's explored and currently available. Looking at things that get absorbed transdermally through the skin so that it avoids the GI tract is a way to kind of help supplement dopamine management without having to rely on oral carbidopa, levodopa, looking at extended release and delayed release tabs. So even if it gets stuck in the stomach for a long period of time, by the time it gets out to the intestine, there's still a little bit there that can be utilized to be absorbed. Intranasal sprays, again, to avoid the GI tract. So GI dysmotility and gastroparesis is something that really can wreak havoc on medication absorption and clinical response to them.
Thank you. And you didn't mention this, but Rhonda mentioned that her gastroparesis means that she's going to look into DBS. And there was some other questions about, let's see, DBS and how long does it work to control your symptoms and can it keep your medicines at a minimum? So could we talk a little bit about DBS
Sure.
in that context?
So DBS stands for deep brain stimulation. It is a surgical intervention for Parkinson's disease. It is obviously, because it's a surgery, not a first line intervention, but for patients that have had Parkinson's for a number of years, they have had a response to their medication, but that response is starting to narrow. They're taking meds more frequently, they're taking higher doses of it, they're adding more supplemental and adjunctive meds. This is the time when the discussion for DBS is usually appropriate. We don't want to do it too early because we want to make sure that we're dealing with Parkinson's and not something that mimics Parkinson's. And also, the one caveat about the medication response is for patients who are tremor predominant. So if you have a coarse tremor that really is not responsive to medicine, that is the one time where sooner DBS as opposed to later DBS may be more beneficial in helping control that symptom or tremor. But really what it's meant to do is enhance that best on time, that best medication response that you're getting. So if you are somebody that's pursuing DBS and you're on medicine, say 8 times a day, theoretically, once you get DBS, you might be able to reduce that medicine to some degree. We say by about 40 to 60%. It matters where you are in your clinical course when you consider DBS. Again, the sooner rather than later idea. So the earlier you consider it, the more robust response you might get as far as medication reductions and things like that. But say you understandably are, not gung-ho about going for brain surgery, and you still kind of like put it off and put it off and put it off, but you ultimately come to the decision that it's what you want to do, but maybe 4 or 5 years have passed from the first time it was mentioned. It is still an absolutely appropriate intervention. The expectation of medication reduction might be a little bit less. And at that point, you might be thinking, well, I'm going to maintain my medicine so that I'm going to get DBS. I'm going to stay where I am and I don't have to increase the dose the way I was doing for the past, 4 or 5 years. So it absolutely can have an impact on the amount of medicine that you take. And it is best suited for patients that are looking to address motor symptoms of Parkinson's disease, tremor, stiffness, slowness, things like that.
There was a specific question. Maybe I'm always impressed by our audience and how much they read and research. At the International MDS conference, they're wondering if the concept of adaptive DBS or any research on adaptive DBS came up.
Yep. So that is closed loop systems are the next line of where the DBS batteries are going. And that is all about software, and not necessarily a change to the fundamentals of the surgery itself. But there is one company now that has the ability to do something called brain sense. And basically what it means is it is able to take a recording of the electrical signals in the brain to see if there is a pattern that emerges when someone is stiff or slow, or if someone tremor kind of breaks through. And if by modulating that electrical activity, which is the way DBS works, it adds a current into the areas of the brain that control movement. So if modulating that electrical activity in some way can dampen down some of those signals, then these things are recordable. And if they're recordable, then they can be acted upon. So it's not totally new technology in the realm of medicine. They have this for patients with seizures and things like that already. But it is new in the movement disorder world. So if they can figure out the patterns that are most commonly related to certain types of movements in Parkinson's disease, then they can essentially program the battery to reactively respond to those patterns and adjust the level of current voltage, whatever it might be for the particular battery that it might be, to dampen down those signals so that the abnormal movement doesn't occur or occurs to lesser degree.
And we actually have on October 4th a whole hour talking about the closed loop DBS. So stay tuned for our emails and check that one out, and we can talk in depth about more about adaptive DBS or closed loop systems. Okay, so the next kind of category of questions, because Dr. Farmer doesn't have your chart, and you're not her patient, or your loved one isn't the patient, so she doesn't know the full story. So that's a caveat for you, Dr. Farmer. But people have put a few different situations in the chat, and let's see. One says, "My pills aren't working optimally." Someone else mentioned they are on Rytari every 5 hours and have a rolling dose every 5 hours. They wake up in the middle of the night. Someone else mentioned, they're on Rytari, amantadine, Azilect. So I know you can't individually, give each person advice, but your wisdom knows no bounds. So is there any general comments that you'd address to these folks with specific questions?
Sure. So you're describing wearing off phenomena with the that the pills that you're taking are not working as well as either they once did or they never quite worked that well. And when a patient comes to me to discuss this, I will tell you that my treatment strategy has evolved over time. So when I first got out of fellowship about 10, 12 years ago, I would not want to necessarily increase your levodopa at that point, and I would try to add on other things, whether they be to complement it, whether they be dopamine agonists, whether they be COMT inhibitors, entacapone, apicapone, whether they be MAOB inhibitors, rasagiline, selegiline, Xadago, things like that. So I will say now that I have changed a little bit to trying to maximize the levodopa more. And it's not because one way or the other was wrong. It was more a feedback from patients and a observation on my own that while we have everything available at our disposal, sometimes keeping things a little bit more simple, a little bit longer goes further. So if someone was just on levodopa and they were only taking it 4 times a day, I might go up to 5 or 6 times a day before I then add on something else. I still use polypharmacy consistently, but like I said, I try to keep it as simple as we can, for as long as we can, because compliance will improve, patient satisfaction will improve, things like that. So frequency is important. Anything more than a 5-hour window, even on Rytary and things like that, is really pushing the expectation of what this medication can do. So I end up doing a smaller dose more frequently, as long as patients feel comfortable taking a smaller dose every 4 hours, every 3 hours. I don't really go much past every 3 hours because then that just becomes hard to do. And that's when I'll add in the other things. And then I will base that on the symptoms that we're trying to manage. So if it is someone that feels like they do get a good response to levodopa, but it's just not quite where it used to be, I might give something to enhance the response of levodopa, whether that's bringing on board one of the recyclers, a COMT inhibitor or an MAOB inhibitor. If they are getting a good response to levodopa, but they're feeling like they don't necessarily want to increase it, or there's a little bit more stiffness and rigidity, then I might look to Noriance or something like that, because it works in a slightly different way. It's not levodopa, and it is something that it's not dopamine. I mean, it's something that can be a complement to it. The reality is, usually in my clinic, patients end up on 2 or 3 different types of complementary medications. Based on discussion, based on rationale for what the symptoms are that we're trying to address, to see how we can best manage the symptoms. But it is, again, when you're having that discussion, I'm on 2 or 3 different meds, and then I don't feel like they're working as well, and I don't necessarily know if I want to increase it, then that's where the conversation turns to looking to some of the other more surgical interventions.
I knew you could answer 3 questions at the same time without specific. I guess there's a lot of tools in the toolbox, a lot of different types of drugs. And I think the last stat I will point out from the survey had to do with misconceptions about adjunctive therapy
Mhm.
that the survey, and just to summarize, people thought that the more drugs they were on, the more medications, that meant that they were doing worse, or that their symptoms had progressed and they were in an advanced stage.
Mhm.
So, if you could briefly address, you mentioned that term polypharmacy. Is it as simple as, if the more pills in my pill box, that means that my Parkinson's is getting worse and worse?
Mhm.
True or false?
I would say false. So we manage symptoms. Symptom, and people who are listening are going to say, well, this is all semantics. And it is semantics to a certain degree. But it is also important to keep the perspective that we expect symptoms to change with time. The changing symptoms do not necessarily mean disease progression. Progression is when symptoms change, but they have such a marked impact on what you're able to do that the level of function is markedly less. So if your symptoms change and you're noticing a little bit more balance problems and a little bit more tremor, but a simple tweak to your medicine or the add of another medicine on board or a round of big therapy or Parkinson's wellness recovery or rock steady boxing, whatever your flavor preference is, and you respond to it and you can tell that there's been an improvement, and that's not necessarily progression. That's just the change in symptoms that we expect over time. And I will clarify this by saying this is my perspective of how there is no definition of advanced Parkinson's disease or things like that, but this is how I approach it in my thought process and in my clinic. If we do make those changes, if we are adding on medicine and we're not noticing an improvement that we would like to see clinically, or you are going through the therapies, but you might not be back to your baseline and a little bit below, then I would say then at that point in time, there is some progression, but it's not to a point where it's progression that means that you've exhausted all your possibilities or that you have, nowhere left to go, getting back to that first thing that we were saying, that there's absolutely nothing left to do. We are dealing with a chronic progressive condition, but we are also dealing with one that has such great strategies that we can keep it fairly consistent for a long time with minimal interventions. Yes, somebody that has had Parkinson's for 10 years that is now considering DBS because their symptoms are not as well controlled, they have progressed, but you're about to undergo a phenomenal treatment strategy that can help reduce the impact of some of those symptoms that you had, again, essentially restarting the clock on what your symptomatic progression will be. So it's a relative term. And I don't want patients to think that because we make changes or because we suggest other interventions, it's because we're at a point where there is nothing to do or they've progressed to a point of no return. The sheer fact that we can make the changes means that they haven't.
Very good. And I think because we know or we hear in other disease states that there's stage 1, 2, 3, 4, sometimes people want to assign that numerical scale to Parkinson's. So
Mhm.
so good to have you share a little bit more insight about
Mhm.
that. And we didn't get to all the questions, but there are some upcoming programs. So on October 5th, we talk about Parkinson's and exercise. So to the person who asked about exercise and medication. And then there was a question where we have Dr. Pontone also in October talking about anxiety and Parkinson's. So to the person asking about a loud environment and stress and affecting their Parkinson's, we'll tune in for that one. We have a lot planned. Thanks. Kelly put the link in the chat. We have a busy October, tons of great topics, tons of great speakers. And Kelly, before we close, could you do a screen share um, for those of you who want to see and read more about that survey that we've been discussing today? This will be linked in our video library, so you'll be able to, read the statistics and see the breakdown. And as always, it usually takes, okay, it's Friday, but so give Kelly a little bit. So early next week, she'll have the recording uploaded, and on our video library, it will have the those written results, and there's some nice graphs and whatnot of the off time survey. So you can check that out, and that would be a great complement as you digest, what we talked about with Dr. Farmer today. So thank you so much, Dr. Farmer, for joining us, and thank you all for tuning in and having some great questions and discussion. We always like to close, invite everyone who has their video off to turn it on, and we have our 5 seconds of long distance eye contact and smiles where we can scroll through and see everyone who's been learning alongside with us. Thank you all for tuning in. Thank you again, Dr. Farmer.
Thank you. It's
Great
always a
event,
pleasure.
everyone.
Bye-bye.
Bye now.